So William Hunter in the 18th century understood that it's very hard to recreate normal cartilage. So the idea of the osteochondral allograft is to bypass all of that and just implant intact, mature hyaline cartilage, not try to grow anything because it is very difficult to recreate hyaline cartilage. We understand bone healing by creeping substitution, and as we've talked about with microfracture, if you disturb the underlying bone, that has an effect on the cartilage. And studies that have previously performed microfracture that then go on to have other procedures where you try and grow cartilage, they do significantly worse. So we can think of cartilage as a unit with the bone underneath. And in terms of the technique, you will either get given a core, depending if it's a smaller size, or you'll have a hemicondyle, which you create your own cores on the left three pictures. So that's the hemicondyle you get given. You create as many cores as you need. You can just do a single core, or you can do a so-called snowman or MasterCard technique. You then will ream out on the associated defect, and then it is a press fit. And this is the final picture here. So in terms of evidence for osteochondral allograft, NHS England did do a rapid review, but they limited their scope to just looking at osteochondral indications. Therefore, they sort of neglected a large amount of the research. In 2019, ESCA commissioned this clinical and cost-effectiveness review on all allografts. One part of it was looking at osteochondral allografts. And we found that it was significantly very cost-effective. So cost per quality, less than £5,000. NICE will fund anything that is less than £20,000, so well within a range that they would accept in terms of cost effectiveness, and even in the revision setting, it's still very cost effective. These are the broad survival rates that across all studies, but this does include all studies which mainly come from America, and they looked at everything. So degenerative joint disease, essentially arthritis, in which the survival rate is worse. The indications that we use, survival rates are better, so osteochondral lesions, OCDs, etc. But it's very hard, so I'm not quite sure how NHS England unpicked the studies because they aren't separated in most studies. In Coventry, we have 56 patients out to a year now, one failure so far. We're still early in follow-up, but PROMs broadly match those in other studies, and failure so far, again, no major early failure issues, but we can't take much more from it because it's so early in the follow-up, but reasonable results so far. So if we don't have an osteochondral lesion, but it is a significant size, then we have the option of ACI. ACI has also been looked at by NICE for many years and rejected for many years. Finally, in 2017, they reversed that decision, and that's mainly out of the result of new evidence, new randomized controlled trial data. So in order to be funded in the NHS, you need to have a defect over 2 square centimetres, no previous cartilage repair, and minimal arthritis. The rationale for ACI is that chondrocytes, as I mentioned, produce and repair hyaline cartilage. When we do a bone marrow stimulation, we are relying on mesenchymal stromal cells, and in microfracture, that's what we're relying on. But we have very few stromal cells that migrate, with some quotes of less than 100 per clot, which is a tiny amount. In healthy cartilage, we have around 10 million chondrocytes. The idea of ACI is that you expand the chondrocytes out of the patient, and you implant a similar number or even greater number to try and create hyaline cartilage, although that is with variable success. The evidence was from 4 main randomized trials at the time, and NICE concluded there was some evidence that it was effective. Cost per quality was actually over 20,000, which is borderline whether they'd accept it. But because they decided that the best patients, so the ones that didn't have a previous cartilage repair, if you didn't include those, it was likely to be under 20,000 cost per quality. So it's just sneaked in, essentially. And Spherox is our main option in the UK. We have much less data on it because it is new, but there was a study produced in 2023 at 3-year outcomes which broadly match other ACI. So NICE are happy with that. So for chondrics, I won't talk too much on about this. James has mentioned it. What it's trying to address some of the issues that we have in the UK. So really long waits for osteochondral allografts. We have only small cores available, otherwise you need to have a hemicondyle, which makes the waits even longer. And cell viability decreases with each day and each week. And we're usually implanting them by week 4. So the cell viability is low, and we don't know what long-haul flight does in terms of radiation. It is certainly not going to improve it. And there's limited indications. Prochondrics is cryopreserved in the cryoprotectant, and the industry-owned studies show that the cell viability after freezing it and then thawing it 2 years later was 94%. So if that can be reproduced, and we are going to do a study looking at that, if that can be reproduced, then that would be really good. So it does address those issues, but as I say, there is not much clinical data on it at the moment. We're doing it as part of a study so far. And then, again, James has touched on this. You can use scaffold-based procedures for larger than 2 square centimetre defects, and there have been a few studies. It is very light, actually, the literature, but there are a couple of studies, and they are starting to come out now. So we have 10-year follow-up, albeit there are small numbers in this, but it is superior to microfracture with both sutured and glued AMIC procedure with this, and it has been approved by NICE as an option in cartilage defects. So in summary, we need to assess the cartilage in the context of the whole knee. I've banged on about this with the meniscus transplant as well, but it is critical. You can't look at cartilage in isolation. You need to choose the repair based on the size, based on bony involvement, and also patient wishes, single stage versus 2-stage. And we need to work together with cartilage centres because we can't reduce options for patients based on where they live. Hopefully the cartilage centre thing will evolve over time, but where we are at the moment, we need to have the discussion with the patient, what is best, and then refer or work with cartilage centres if those things are appropriate. Thank you.